college who are responsible for the creation of this fulfilling platform. Dr. P. Chinnadare, MA PhD, Secretary and Correspondent of PANIMALAR Institute of Technology, our directors Vijay Rajeshwari and Sakti Kumar ME and Mrs. Saranya Shri Sakti Kumar BE. I take pleasure in also inviting our principal, Dr. T. Jayanti, who has been great source of inspiration to us. I extend my pleasure in welcome our speaker of the section, Dr. S. Ganesh Vaidyanathan, Principal, Sri Venkateswara College of Engineering, Chennai. They
Good
say
morning, ma'am.
Gaining knowledge is the first step to wisdom, and sharing it is in the first step to humanity. Knowledge has no value until it's used or shared. True power is gained by sharing knowledge, not by hoarding it. Actually, you are not just helping others, but yourselves too. They say knowledge increases by sharing, it's not saving. You know what? I say there are 5 steps to make this work. Listen, be quiet and attentive, preserve it, practice, and finally spread the knowledge you gain. To do this, we have the most intellectual resource person waiting to serve us with their knowledge for the next 5 days. I extend my heartfelt welcome to all the participants who join us for the AICT Atal Academy FDP and Medical Image Processing and Deep Learning Technologies. So once again, I welcome you all. So welcome, sir. Thank you for coming this FDP. Thank you so much. Thank you once again.
Thank you, ma'am. Before introducing our chief guest to this August gathering, let me give you a few points that to be noted for the FTP. The points to be noted during the faculty development programs are, it's just like a guidelines that to be used. You will be given with the same Google Meet link for all the sessions. Try to use the same mail ID as registered for the faculty development program. Kindly mute yourself during the session for smooth conduction of the course. Any queries, kindly post it in the chat box, and kindly fill the feedback form for each resource person at the end of the session. The Google Meet app records your attendance. Mandatory attendance is 80% for successful completion of the course. At the end of the program, the test will be conducted, and you need to score a minimum of 60% mark for successful completion. At the end of the program, to your participation login, you have to fill the feedback form given by the Atal team. We will also brief the same in the last day of the program. And I would also like to give you a small intro about the formal inauguration that is happening today by 11 a.m. The formal inauguration will be streamed through YouTube Live, and the link will be posted in the chat box as well as in the WhatsApp group. I request all of you to join the session post completion of the first session. Now I call upon Dr. M. Prem Kumar to introduce the chief guest to the August gathering. Welcome, sir.
Thank you, dignitaries. So good morning, one and all. So now I'd like to introduce our session eminent speaker, Professor Dr. S. Ganesh Vaidyanathan. So who is serving as the principal of Sri Venkateswara College of Engineering, Sri Perambudur, Chennai. So Dr. S. Ganesh Vaidyanathan sir has completed his PhD in Development and Performance Evaluation of Processing Techniques of Automatic Karyotyping from Anna University, Chennai. Has completed his ME in Mechatronics from Madras Institute of Technology and MS Electronics and Control from BITS Pilani. So Professor Dr. S. Ganesh Vaidyanathan has 30 years of teaching experience and very rich research experience. Dr. S. Ganesh Vaidyanathan has guided and is guiding several research scholars for their doctoral PhD programs and has published several research papers in highly reputed journals and international conferences. So Dr. S. Ganesh Vaidyanathan has been invited to deliver talks at various reputed institutions around the globe. Dr. S. Ganesh Vaidyanathan is an eminent researcher and is an academician and who's serving in the field of engineering for the past around 30 years. And sir has also organized several workshops, short-term training programs, faculty development program, conferences sponsored from AICTE, DST, and also other organizations. With this high profile, I request Professor Dr. S. Ganesh Vaidyanathan to take over the session, sir. Sir, please, can you take over the session, sir? Thank you, sir.
Yeah, thank you for the kind introduction. Respected management, principal, the head of the department, and the organizers of this IETE FDP program on medical imaging and deep learning. And my dear participants, the faculty from various institutions, a very good morning to all of you, and I hope you're all taking due care of yourself and your family. I'm thankful to PIT for, am I audible? Can anyone do me an audio
Yes,
test?
sir. Yes, sir.
Thank
Yes, sir. It is audible, sir.
So I thank PIT for giving me this wonderful opportunity to address, the faculty members from different parts of the country. I'm happy to see that the response is overwhelming. And I went through the schedule of this FDP. I'm finding that the schedule has been very thoughtfully conceived, addressing different topics which are very much essential for this particular FDP. Like eminent industrialists have been called, who are working in the field of medical imaging and deep learning. So I'm not an industrialist, or I'm not from an industry. But as mentioned in my introduction, I think I have gathered enough knowledge by guiding many of my research scholars who are mostly working in the area of applying artificial intelligence to address the problems in healthcare. So mainly my research scholars are working in the area of cognitive disabilities, like hearing, speaking, and even we are developing a system for the blind. So with this varied experience, I have gathered some information which I thought I would briefly share it with you. My presentation is only having some 20 slides because I know it's an introductory lecture. I don't wish to go too technical about it, but I'll later on share my contacts through the coordinators to all the participants, and you are all welcome to get in touch with me in case you have any doubt. We can always share our thoughts, and we can learn together. So with this, I once again thank the organizers, and thank you all for gathering here to listen to my speech. I'll just load my presentation. I would like the coordinators to please tell me if the presentation comes on the screen.
Yes, sir. Yes, sir. We'll tell you, sir. 1 second, sir.
Sir, may I have a check, please, whether the presentation has come on the screen?
Yes, sir. Presentation is visible, sir. You can kindly go ahead, sir.
Okay. Thank you so much. So again, the topic that I have chosen for the day is imaging and deep learning in healthcare. In fact, the topic of the FDP is medical imaging and deep learning. So I also chosen to give a briefing about the same topic. So to start with, I would like to tell you that there is a paradigm shift in the healthcare field. What is it? That is nothing but the introduction of AI, because traditionally healthcare has been provided only by humans, that is through natural intelligence and not through artificial intelligence. Whereas we are in an era where we find that computers are playing a major role, that is by providing artificial intelligence, right? Which is certainly advantageous in many ways, and also to some extent a little disadvantageous as well, right? We will finally see what are the demerits also. So, but no one can refute the fact that AI in healthcare is a paradigm shift. Whereas we can understand that AI can very well go into industrial automation, or it can get into making our life better, right? Most of us even use now Alexa and the Google and all to get our suggestions, to get the optimal route and things like that. That is all quite understandable. We certainly need the help of machines. Whereas when it comes to healthcare, our reliability is mostly associated with the physicians, right? That is the doctors. Whereas AI is slowly, trying to, get into this field. And there is also a projection that unless or otherwise the physician is really an expert in the area, it may even wipe out the so-called what do you call this a physician what do you call role itself. This may be an exaggeration, because going by the fact that so many children they do suicide and things like that because they are not able to fare well in the NEET, and still medical profession is considered to be the one of the most aspiring professions compared to engineering or any other professional program in our country, I mean. Whereas you find that AI is slowly getting into this, and unless otherwise the individual is technically very qualified to become a physician, it's quite sure that we will rather seek the help of AI rather than the human being himself. This no one can, I think, refute, right? Okay, now let's see first what the report from Accenture it says. It is there on the screen. You can see the investment as far as the health AI market is concerned. In 2014, it was $600 million US dollars. You may be asking me, why don't you talk in rupees and why in US dollar again? Have I simply flicked some data from the net and showing it to you? To be very frank with you, AI in healthcare around the globe is actually booming with the knowledge given by Indians. There is no doubt about it. Take the case of Microsoft. Take the case of Google, the Alphabet. It is also listed there in the screen. They are all major players of AI in healthcare. You will find these are all driven by the Indian brains. But unfortunately, all this investment is only done in the foreign countries, mainly in the USA and in Europe. In India, we certainly have all these applications, but only at the service level. Strictly speaking, India is not in a very major way involved in the development of AI in healthcare, because it requires a huge cost of infrastructure. A lot of money is involved, though a lot of startups are now coming up, but they tend to contribute in their own small way. Whereas the real investment, it comes from the Western world. That's why all our figures are there in the dollars. Okay, so it's not that I'm still a patriotic person. I would like all these figures to be in Indian rupees, but unfortunately, this is the reality. So $600 million in 2014 to $6.6 billion right now. It is going to be 2021 now. You find that the multiplying factor is 11 times. So this is a very apt example of why companies are seeking to invest in artificial intelligence, particularly applied to healthcare. Now, if you want to know again what are the sub applications of AI in this healthcare field, you can see some 10 areas that in which the industries are looking for more investment. On the top of it, we find that it is a robo-assisted surgery, which is slowly gaining prominence because of its precision. Remember, I say only precision and not accuracy. Okay, accuracy is always appreciated only by human beings. Whereas when it comes to machines, you can always say machines are quite precise, which means the reproducibility is excellent, right? But when it comes to accuracy, if not the human being is, if the human being is not involved, I don't think machines can talk about accuracy itself, right? So robo-assisted surgery is going to take the topmost investment of nearly $40 billion, right? Then going to virtual nursing assistants. You know something? Singapore has already introduced a concept called as virtual nursing assistants and preliminary diagnosis through chatbots and artificial intelligence. We all know what are chatbots, right? Chatbots are applications which talk to the people, and they make use of AI techniques to give optimal solutions. Singapore, a country, has already introduced this chatbot kind of preliminary healthcare analysis, especially in view of COVID, because we know under this COVID circumstances, we are not in a position to travel a lot or go and meet physicians. So Singapore is now giving a lot of prominence. It has also invested a lot of money in this particular thing. Now you can also see there are other areas. You may be wondering why cyber security is there, because all these healthcare applications, they take the data from the individual. As per medical ethics, sharing the data in a public domain is unethical. So they have to also ensure that suitable security has to be provided for this data. So $2 billion is the investment to study about how good the security can be, so that the norms related to ethical the hacking or ethics pertaining to healthcare is complied with, right? So you can see like that there are many other areas. Since the presentation is going to be shared with you, I don't want to read out everything. And you can also see in this slide there is a competition dashboard which talks about the major players. You'll be surprised to see like Microsoft, Microsoft Inner Eye. I hope you would have heard about it. If not, please go Google and find out what Inner Eye does. Inner Eye talks about AI techniques, which is used to, study about the internal, the diagnosis of our internal organs. And they are coming out with a lot of, AI tools. Most of them are even open source, and we can freely use them. Alphabet, Sundar Pichai is now the CEO of Alphabet, which is a subsidiary of Google. Then you see NVIDIA. Most of us know NVIDIA is a very good hardware provider for gaming applications. But now with the advent of medical imaging, like complex medical imaging, the support of NVIDIA is very essential. IBM for computing, Intel for computing. iCarbonX is a company which is a specialist in genomics, right? So there are many big players who are also taking part in this AI in healthcare. So it's quite evident that this area is gaining a lot of prominence. And many of you, I think, even will be now looking at your research area as applying artificial intelligence in healthcare. I'm quite sure that you're in the right direction. It's quite a promising, area. Now, the second slide shows why this paradigm shift is happening, right? What is the need? The first thing, with the due respect to all the physicians, even whom I am consulting with, right? Certainly it is because of the declining expertise of the physicians. You may be shocked when I say that the physician's expertise is declining, but this is the fact. It has also been proved, and I'll show you later on one of the slides which vouches for this particular, claim. Why is this expertise of physicians declining? It is again because of AI. You know something? Doctors are more tech savvy than engineers, right? Because more than what we do, because probably we belong to the same domain, and going by the proverb that, the quote that familiarity breeds contempt, we have a little bit of aversion towards technical things, whereas the doctors, being people of a different domain, they are certainly attracted to this particular, technical stuff. And most of the doctors are tech savvy, I have observed. And when they become more and more tech savvy, their natural expertise for treating people, it declines. It's very obvious. It has been proved also through statistics, right? If you go to reports by McKinsey and probably many other agencies have done this survey, you will find that this has been proved. Okay, certainly doctors are not as good as what they were probably about 50-60 years back. The expertise is declining, but on the contrary, they gain more knowledge and they have more reliability to technical things or using gadgets. For example, this cartoon aptly describes that the doctor tells the patient that I looked up your symptoms on Google. If you're not satisfied, again, I can again check with Yahoo, right? This is really a fact that doctors also rely on the computers for many things, okay, rather than applying their own mind, because the information is very complex and it requires a lot of patience and perseverance to do things, right? The second reason why this paradigm shift is happening is the high rate of information. Though doctors, the physicians' expertise is declining, but still, if you look at the number of patients, okay, approaching big hospitals like in our country, Apollo or Fortis or whatever, right? There are so many chain of hospitals, big hospitals, which actually use AI in healthcare as well, right? If you look at the number of patients, the influx in these hospitals, it's very, very high. So that way you find that the information gathered from these patients and presented to the doctors is also getting a lot of, it's becoming very high. Above a certain threshold, it will be highly impossible for the physicians to handle this manually. For example, you take the case of an MRI scan for a patient. It can range as well from 64 slices to 256 or even more. It depends on the volume of the region which you want to cover. No, we call them as voxels or whatever, right? So the slices, with many slices, you cover a larger volume of the tissues and other things what you want to study. So higher this information, naturally the physicians will seek the help of the computer for assistance rather than understanding and rather than coming out with interpretation, because there is a danger that higher rate of information and high complexity of information, there is a danger that the physician may come out with a wrong diagnosis, okay, because of what? Fatigue, obviously. I came to know that going by the influx of the patients in the various hospitals across the country, an average radiologist will have to interpret images at the rate of 4 to 5 images per minute, which is quite scary, right? It is even more than what the software engineers do. We say software engineers, they do coding for 8 hours a day or 12 hours a day, and we say that sitting in front of the computer is dangerous, right? Doctors are also exposed to the same kind of, sitting with the computers and interpreting things. There is no other go, right? Because of the high volume of information. And as I told you in the earlier slide, the precision of operation, right? Certainly AI helps in achieving a very great precision, leaving out accuracy, all right? Again, I always say precision because the accuracy still, even in this advance, many countries say that they are very advanced in terms of AI, but you will find that the accuracy it still cannot be matched to that of a real human physician expert. So take the case of some, a well-known physician. Okay, no AI system can still match the accuracy of this human expert, but we can very well say that the precision is high. For example, what's the difference between accuracy and precision? Most of us who are learned instrumentation we will be able to appreciate that. Accuracy is the ability to do things in a more error-free manner. Precision is reproducibility. Precision has nothing to do with accuracy. You can do something wrong, but if you're going to do it without much of deviation, even the same wrong thing, you're going to do it again and again without variations, you say that you offer a good precision. So that way, leaving out the accuracy, the precision of the operations, even an MRI machine is going to do scanning thousands of times in a day. Its operation is still going to be precise. Okay, so that way, these are all some of the reasons, main reasons why AI in healthcare is becoming a paradigm shift. Now, coming specifically to our topic of the FDP, that is the use of imaging in healthcare. So if you look at the three main applications of imaging, we would say that imaging is used for diagnostics, which means you just find out what is the malady, or what is the what is the patient suffering from. An example for that, you know very well that X-ray is the most common imaging technique which is used for diagnostic purposes. Of course, some X-rays are also used for therapeutic purposes, but we will now say that it's a common X-ray which is used for diagnostics. The CT scan, MRI, the ultrasound imaging, I mean. So all these things are used for diagnostics. Ultrasound can even be used to identify the sex of the fetus, right? Then the second area where imaging is used is guided therapy. In some cases, to do treatment, we seek the help of imaging, right? The medical imaging, which will help us to guide the therapy process. For example, angioplasty, which is used to remove the blocks from the blood vessel by inserting a balloon catheter. This image shows that the catheter is being inserted, and through an imaging technique, we are able to see the path through which the catheter is inserted, and ultimately it will reach the place where the block is. The balloon is inflated, and it's supposed to, remove the block and insert a stent, right? And laparoscopy, most of us know. Laparoscopy is an imaging come, an operation kind of technique where either it can be used to do some biopsy kind of thing, or used to remove some sort of cysts and other things. Most of the females know about PCOD, right? And laparoscopy is a very widely used, technique where imaging is certainly, going to be very helpful to the physicians to do this treatment. And the third one is theranostic applications. What is theranostic? It's a combination of therapeutic cum diagnostic. At the same time, when you diagnose what is the disease, and if you find that the disease is there, we also do a treatment. We also carry out a treatment. That's what is a theranostic. Theranostic is therapeutic plus diagnostic. That is theranostic. A very common example that is given for theranostic application is peptide receptor radionuclide therapy. You can see in the slide, I have shown an example to the rightmost. It's a thyroid gland. The above one with the blue color is the tumor. The blue color region is the tumor in the thyroid, okay, which shows that there is a thyroid cancer present in the patient. And with an isotope, with a radioisotope called iodine-131, right, we are able to diagnose that the tumor is there in the thyroid glands. That's what is shown by the purple color or the blue color. Subsequently, the same iodine-131 is also used to give a radiation therapy to remove this tumor. And you can see the same gland after the treatment using the same radioisotope, or sometimes they use different isotopes. It's called as a surrogate PRRT. Whereas in case of some PRRTs, the same isotope is used for both diagnosis as well as for therapy. Example is iodine-131. In some cases, one isotope is used for identifying the malady, and the other isotope is then used for treating it. They release it only when it is needed, right? So you see that the tumor, the region of tumor is substantially, it is overcome in the second image. Okay, so these are all some of the applications in which we find that without the help of computers, right? You see in all these images, especially in the first X-ray image, you can see there are a lot of data that are picked up by the machine, and it is presented to the doctor, right? In some cases, even the machine show the dimensions of the the tumor, or the dimensions of the various portions of the body, and what is the coordinate. So without all this, it will become very difficult for the physicians to locate and then give appropriate treatment, right? So all these things are not possible without the help of a computer program. That's why we say that to start with, we all know artificial intelligence, even a small program in a computer, we can say when the computer is able to mimic something which the human being is supposed to do, we say that it is the case of our AI, right? So even a small program written to assist a doctor, right? In all this, we can actually call it as an AI application. So AI is very much, essential in the present scenario, without which 90% of the operations that the physicians do becomes virtually impossible. So probably very simple things like whether you have fever, and now we all are experts in finding out what is the oxygen saturation, what is the pulse rate and all. I think most of us have a pulse oximeter. We do all this testing at home. We all become small physicians, right? And we also suggest what is to be taken for COVID and things like that. Whereas when it comes to complex things like all this, obviously without the help of a computer, right, the human intelligence alone, because the volume of information is very large, right? Again, the second one, the next slide shows the second aspect of this workshop or the FDP is you are also going to learn a lot of things about deep learning. When is deep learning suitable? We all know that deep learning is suitable when the data is very complex and unstructured, and the three V's, right? Especially with the big data, the big complex unstructured data, like unstructured or structured or whatever, right? You call it all as variety of data, right? So the volume, the velocity, and the variety, right? So many things are now being talked about. In fact, all these things are very much pertaining to the healthcare. You see the 6 images shown here. I'll just explain what they are one by one. The first one, which looks more like the cockpit of an aeroplane, is actually a neonatal ICU. You can see a small baby is actually lying here, I don't know if it is very much visible to you, right? So this baby, for this baby, so many parameters, a lot of sensors are hooked to this patient, and a lot of parameters are acquired and monitored, and even treatment is given. So sensory data obtained from one patient itself, imagine if it is going to be this much, imagine there may be hundreds of patients in one hospital, and there may be lakhs of patients in so many hospitals, right? So it is certainly essential for us to acquire everything, then interpret it. Is it possible for a doctor or a nurse to look at every monitor and remember what is happening and give an alert or something? It's virtually impossible, right? So certainly we need an analytical tool, okay, so which will help us to continuously monitor and interpret what is happening. The second one, as I mentioned earlier, is the MRI. A typical MRI machine, when you go for a scan, may get you around 64 to 256 slices, depending on the volume or the region which you wish to cover, right? So it's very obvious that, okay, the data is so much that it is impossible for the physician to go through every one of the image and find out if something is wrong with that. This is where we find the use of deep learning, which is also a derivative of artificial intelligence, right? We say that ML and DL are, the two, they all come under AI, right? So since the data is so much, and processing or interpretation requires a lot of effort, so it's very much essential. The third image here to the right, I'll just use my pointer. Yeah, you can see this image here is actually a snapshot of a patient record system. I'm sorry that it's not very clear. You can see even some of the images grabbed from the patients are listed here, and on a daily basis, as long as the patient is there with the hospital, what are the parameters, who has given the treatment, what is the prescription, everything is going to be stored in a patient record system automatically. Some of the inputs are given manually, whereas some of the inputs are acquired from the servers. For example, this ICU here may be connected to a server, and probably all the data may be acquired and data may be logged in. So this patient record system may even import the data from all the servers, and it may fill in the appropriate field. And one of the most challenging things in healthcare is transcription of medical notes. This is a very big business, earning into billions of dollars. Here you can see that I'm showing two images, not very clear though, which looks like the prescriptions and the case history noted down by a doctor. I'll come to this part later. Some of the deep learning things like LSTM or to understand the natural language. See, every doctor uses his or her own language, right, to record the case history, and they also write in their own way. I would say that probably this is all a kind of unstructured data, right? This unstructured data certainly needs the help of deep learning to parse it and then interpret what is being said. Then drug discovery. I think most of us know about this because we are all eagerly awaiting the appropriate COVID vaccine right now. Starting from a whopping 10,000 candidates, right? That's the first step. We call it as target identification. Then they identify which are all the potential, candidates, the combination of chemicals that would treat or that would combat virus or bacteria. The lead, shortlisting the candidates, then lead optimization, which would be the most optimal chemical combination. Because it has to be economically viable. It can't be a very costly, medication. So that way, lead optimization is carried out. Then finally, preclinical trials, where the trials is carried out in the laboratory with the help of some animals and other things. Then later on, it goes to clinical trials. I think most of the COVID vaccines done by very famous laboratories now are in this clinical trial stage. And finally, if people are found to be safe, and when all their parameters are going to be normal without any adverse effects, then we go for the drug approval, and that is when it comes out as a drug fit enough for the public to consume it and to get treated. Now, why I'm saying this is it possible to maintain all this data and follow? It's actually more complex than a software development life cycle, right? In fact, It's only with the help of computers you will be able to do something called as a drug discovery. Even this lead optimization and other things where they find out how which chemical combination acts on which part of the DNA. You can see here the symbol here refers to the chemical molecules interacting with the DNA of the target organism, right? So the DNA is such a a long sequence, and we have to actually target the appropriate the portion of the DNA so that the organism is destroyed, right? So this is all a drug discovery process which certainly needs the help of a computer. And last but not the least, which is slowly gaining popularity, is the clinical decision support system. What's a clinical decision support system? Like most of you would have now heard, no? Even the many public are now having some kind of sensors implanted in their body, especially sensors for monitoring heart rate and sensors for monitoring the sugar levels are put on the body. And through a wireless or through a periodic see, there is a what you call a kind of memory which captures and stores the values of these parameters. As and when they visit the physician, the data can be downloaded and analyzed, like for example how the pattern of glucose assimilation has taken place in the patient, or whether the patient has undergone any kind of abnormality in its heartbeat. Or it could even be in advanced countries, this has gone to the extent of being processed in a remote fashion. You don't have to visit your physician at all. By being in your place, through a GSM or whatever, a CDMA network, you can transmit this data, like it's through the IoT, right? Through the IoT network. Then it goes there. It is compared automatically with the patient's data as well as the reference data. Okay. If the patient is going to have some abnormality, then the physician is alerted. If the patient is also warned of any kind of the algorithm does a prediction of the data is going like this, so you be aware that you don't allow it to further shoot up, say your body glucose or something like that. So there are a lot of things, see, all of these areas like sensory data processing, image analytics, patient record system, some are old and some are new, whereas they are very complex, and they are themselves a separate research area. So it's very essential that artificial intelligence is to be used for all these applications. I'm sorry, 1 second. Yeah. Just to relieve your monotony, I thought initially this topic is going to be for 1.5 hours. So it is always my habit to relieve the audience of the monotony by making you laugh at least, if not cry, right? So you see the first image here is the real prescription which I have scanned and taken from a doctor. This is how typical handwriting is. The second one is another joke about how doctors perceive the alphabets. So the third one is someone is saying that I got an email from the doctor and he is using a really weird font, right, which is similar to his writing. And last but not the least, the image here, it says that, see, doctors are not born with a poor handwriting. But do you know something? 90% of the physicians have a poor handwriting. That's what, again, statistics says. I don't know how engineers are. I don't think any statistics was done on that. But doctors, they have found out that through their prescriptions, 90% of them have got a very poor handwriting. But it's not that it is a born trait. You see that the doctor's handwriting is like any other child, is good in the beginning. And once they come to practice, their handwriting becomes really horrible, right? Anyway, this is just to relieve your monotony, and let me go to the next slide. Okay, right. Now, as I told earlier, why deep learning? Why all these things we should say come under the purview of deep learning? Yes, as I told you, please look at the left-hand side is what I talked about already. The right-hand side says, because of the volume, as I mentioned earlier, genomics. What is genomics? Studying the gene expression. Do you know what is the memory occupied by the DNA? Or in our human body, it's nearly in the order of 1.5 to 2.2 GB, gigabytes. Okay, which means you can't contain it in a CD, right? Probably you need probably a high density CD or something like that. What I'm trying to tell is the volume is so much. Okay, it is even more than a movie. That's why I think our life itself is like a movie, right? So it's so complex and so much that, right, it is not possible for any physicians to, even say a very experienced genetist, right? He can't manually read the gene expression and say that, okay, this is the problem with your gene here. That's because of which you have got this particular problem, and it can be treated like this. It's virtually impossible, right? The number of patients, which was mentioned earlier itself, the variety, as I told you just now, some information may be textual, some may be images, some may be unstructured. Unstructured means as bad as the doctor's prescription. Some may be structured, but however, we still require some data processing and things like that. So volume, variety, velocity. One, frankly, we have to admit that the velocity of data coming from a medical, probably because of high volume, we can say volume doesn't imply velocity. The velocity is generally low, though whether deep learning is still suitable based on velocity, I won't say personally it is needed, because the data does not come at a very high rate. Okay, the data really comes low. Even if you take the ECG, the bandwidth of ECG is only around 125 hertz. So the sampling rate is not going to be that much, applying Nyquist sampling theorem, or say 4 or 8 times the sampling level. So why I'm saying that is, compared to say information which we receive from the internet and things like that, medical data does not involve a very high velocity. They are generally low. However, the volume and the variety are still very complex. So deep learning is certainly a good candidate. Now, I'll just quickly touch upon, I think I have only 15 minutes. I'll just quickly touch upon what is the crux of my topic. So far, I think I justified why AI in healthcare is inevitable, and what are the two, why this FDP has been chosen to cover imaging as well as deep learning. Deep learning, I think even one of the topics was related to processing of biosignals, and one topic was I found in the schedule is based on processing of images. So it has been well thought and formulated, the schedule. Right. Now, coming over to the machine learning, if you look at this image, right, the conventional machine learning, where before the advent of cloud computing and complex computational, algorithms and tools. For example, nowadays most of the researchers use what you call TensorFlow, right, which helps us to easily do or implement a deep learning network or a convolutional neural network or whatever, an LSTM or whatever, right? So it is very easily possible just by downloading the tool, and just we can easily implement those algorithms. But if you look at probably some 20 or 30 years back, where even Python was not that famous, and all these type of tools like TensorFlow and other things, you take even the library NumPy, right? It's so useful, right? It is used to process the bigger arrays. Whereas if you take the same thing in MATLAB earlier, when I used to do the research with MATLAB, it was so difficult for me to define a very big array and process it. Whereas now things have become very easy. By just defining the appropriate library function, you can import a lot of new commands, and you can use them in your program. So earlier, machine learning probably used an artificial neural network classifier to detect the type of tumor, whether it's malignant or benign or whatever. And these neural networks were deliberately kept simple. Why? Because of reduced computing power. Frankly speaking, we never had cloud computing, right? We never had all these advanced tools that can do complex data processing. So obviously our tool, which is used as a classifier, had to be limited in terms of its size. Though theoretically speaking, it can be expanded to any dimension. But practically, the tool should be available, without which it is not possible. We are not designers to develop these things. That's why I said, India, we have the idea, but we don't have the money, right? That is where the foreign countries, they invest so much, right? You must be knowing that NASA's annual, budget is in fact more than the budget that is allocated for whole of our country. right? So more data, sorry, more amount goes into research. So here with the available limitation of computing power, so earlier we used to use a simple artificial neural network classifier, which used to take the inputs like texture and other features extracted from an image, and we used to separately apply some image processing algorithms. Say we used to do image pre-processing using filters, then use segmentation to extract the region of interest. Then from the region of interest, we used to extract features like texture or whatever, right? So many features, whether it's spatial features or frequency features from the frequency domain, that is spectral features, right? So all these things we used to extract, and then those values will be given to the classifier, and classifier will be trained to identify whether the whatever the region that you find in the image. So you can see here this image shows a CT scan and with a tumor, right? So whether this tumor is malignant or benign is actually identified only by this classifier, which is a limited structured or a simple neural network classifier. Okay, whereas it required a lot of pre-processing steps by which you give the appropriate input to the classifier so that the classifier will be able to get you the appropriate decision. Whereas what is happening in the present scenario, you don't have to do all those stuff, right? You take even 256 slice MRI, right? With the help of something like a TensorFlow or something, you can easily define a deep neural network. That's a convolutional neural network with appropriate activation functions and whatever, right? I'm not really going to go into the technical stuff today, but we can always discuss. If anyone is interested, we can discuss, right? So you can see here, so many inputs can be given as the inputs to the layer, the initial layers with which we can identify patterns of local contrast. Then what happens by amalgamating these local contrasts, we can actually get to know the next few layers can be used to actually identify some regions, specific regions. Again, by amalgamating those regions, we will be able to finally say that, okay, this is what is the the kind of tumor, or this is what, based on the training set, this is what is the kind of tumor, and this is where it is present, and based on the texture and other things, this what could be the kind of abnormality. So all those things are quite possible without separately having to do an image processing step, and then applying different types of algorithms, then porting it from the image processing toolbox to the neural network toolbox. All those things are not needed. Straight away you can give the image or whatever. It need not be the image alone. Deep learning doesn't talk about imaging alone, but imaging is one of the most suitable applications of deep learning. Why? Because since the input is very complex, right? Especially with so many images available with the physician, it is impossible for him to minutely look at every image and then come out with a conclusion. So it's very obvious that deep learning is a very important candidate for doing image processing. But the same can also be applied. I think this will also be very useful to interpret the doctor's prescription, right? Because it's one of the most complex inputs. Anyway, I think I flicked this slide from quantum, right? So the image courtesy goes to quantum. So you all know with the deep learning, as I mentioned earlier, after you train the deep neural network with say a set of MRI images, okay, typically it takes, see what I showed in the earlier slide is a two-dimensional one. It can even be three-dimensional in the sense you can have multiple layers in parallel, right? One after the other, and they can all process the various slices taken from the MRI, and which means you can cover a whole voxel, which means on the whole, in a volume of a tissue, you can find out if a tumor is present, and that also can be predicted, right? Okay, so as mentioned earlier, if you're going to train such a type of network, then you will find that this network can actually tell whether the tumor in the image is a oligodendroglioma, or it's going to be a astrocytoma or whatever, right? These are all basically brain tumors of different types, right? An oligodendroglioma, it looks like it has got some legs, like how a neuron has got dendrites, right? Dendrites, you know, are the branches coming out of the neuron. The same way, this tumor, oligodendroglioma, is actually a very tricky tumor. Under normal condition, it may mimic a neuron. Whereas with deep neural networks, they have been able to identify with fairly good accuracy this type of tumor. Astrocytoma is a conventional, tumor with a separate kind of contrast and texture, which is quite easily identifiable as compared to oligodendroglioma. So all these things people have already executed, and they are using it in practical, applications. And I would probably prefer to skip this because this talks about how you actually get it trained. I think most of the researchers here know how to train a neural network. Anyway, I'll give a very brief thing. So what you do is, initially to train the network, you present various inputs from the training set. Then what you do is, you know the ground truth, right? For example, if the ground truth says that it's a tumor, whereas the network says that, it is 32% it's a tumor, whereas 68% it's not a tumor, then you know that the error is 68%, right? So, sorry, the error is supposed to be, it says, the image says that it's 32% a tumor, which means it says that 68% it's not a tumor, so we can say that the error is 68%. So this error has to be translated into an appropriate weightage, is it not? And it has to be back propagated through the various stages, and we need to modify the weights of the various branches of the deep neural network. And as far as the activation functions and other things are concerned, I leave it to you because it's quite a voluminous topic. I don't think we can cover it right now. Probably if time permits, I think we can in detail later. Now, before I come to my final part of the topic, right? I would like to share a tweet given by Mr. Andrew NG. You know, most of you must be knowing Mr. Andrew NG is a very famous tutor in Coursera, right? You would have met him there. He is one of the leaders of the Stanford machine learning group. What is he saying? He says, should radiologists be worried about their jobs? Breaking news, we can now diagnose pneumonia. See, pneumonia is a very important complication arising even out of COVID, right? The coronavirus disease actually, if left untreated, can result in pneumonia. So pneumonia is one of the most important diseases that is now taking the attention of many people. So he says that in 2017 itself, he has said this: we can now diagnose pneumonia from chest x-rays better than the radiologists. You see, if you look at a parameter called as F1 score, they have taken the F1 score from some 4 radiologists, and you find that only one radiologist is actually outperforming the software. The software name is ChexNext. Okay, actually the software ChexNet, ChexNet, right? This ChexNet tool or a software, which is a deep learning network, is supposed to analyze the the chest X-rays, and it is supposed to identify whether the person is having pneumonia. Right, a simple congestion cannot be pneumonia. A more complicated, features are to be extracted, on the basis of which, it has to be proven. You see that 75%. If you take the 4 radiologists, 3 of them have underperformed compared to ChexNet. Oh, I'm sorry. I think 1 second. It's it's 435. You can see that the ChexNet F1 score is 4.435. Whereas the only one radiologist has outperformed just ChexNet, probably is a very great expert, which means the radiologist's average is only 0.387. Now, many of you may be wondering, what is this F1 score? That is where I want to now end my topic by giving you some idea about what kind of performance metric you should adopt, right? So that you will be able to, even if you are a researcher and you're going to do some research in the area of, deep learning or image processing, you should be able to come out with a correct performance metric. Otherwise, things will be interpreted in a wrong way. If you take the performance metric, you see that I have given a table of 40 cases from a training set. But the actual is actually, you know, if the disease is perceived as positive, it is given as P. If it is predicted, it's as negative, it is given as N. Then you all know how you write the true positive, true negative, false positive, false negative. I don't have to tell you about this. So this is a table which actually shows, a sample, training set where what is actual and what is the predicted thing coming out of a network, a classifier, say. So this is the positive region. So in the positive region, whatever is really positive, if it is identified as positive, then you call them as true positive cases. Then a positive, case which is identified as negative, we call it as false negative, because the outcome is false and it is also called as negative, right? So that is FN here. Similarly, all the negative cases, if they are correctly identified as negative, we call them as true negative. And a negative case identified as positive, we call them as false positive, right? So most of the researchers must be knowing, and you must be using this very often as well. Now, what is my contention here is, and accuracy also, you know how to calculate it. Accuracy of a classifier is given by this formula. It's a summation of the correct cases. The cases correctly predicted. That is the sum of true positive and true negative divided by the total of all cases. Now, going by the previous table, here you see in this previous table, I have taken 40 entries, right? So the true positive cases are 6 here. You can see this green region is true positive, so 6, and true negative is this green region, which is 12 cases out of 40. So the accuracy is 45. This may seem to be fairly okay. Okay, fine. We all think that okay, 50% of the cases the classifier has given us the correct prediction. That is fairly okay to start with, right? That's what we will think. But this is not really true. In reality, if you are going to go by this 45%, then we will be doomed. Why? Because there is something called as a accuracy paradox. I'll come to that part later after 2 slides. You must also be knowing about the 2 parameters called sensitivity and specificity, right? So I don't want to dwell much upon this because most of the researchers know about this. So sensitivity is the ability to detect the positive cases correctly. For example, the total positive cases is 20, out of which 6 have been only predicted correctly. So 6 divided by 20. That is 30%. This is the ability to predict positive cases correctly. Specificity is the ability to detect the negative cases correctly. Again, the negative cases that are correctly predicted are 8. Okay, I'm sorry, 12. Right? So 2 negative. I'm sorry. There's a mistake here. It should have been 12 divided by 20. I'm sorry here. So because this is the true negative by true negative plus true false positive, the number is wrong here, so please correct it later, or I'll correct and send the slide again, right? It should have been 12 divided by 20. These 2 parameters most of us know. Now what is this accuracy paradox? Okay, now I'll just want to kindle your thought on something important. Of these 4 parameters, say true positive, false positive, true negative and false negative, which you think is the most important parameter? Is it true positive? A person who is detected with a disease or say some kind of malady, right? If you are going to detect it true, then fine, okay, he's going to undergo treatment and he's going to get cured. So I won't say that is very important. A person who is not having the disease, if you are going to truly detect it as not negative, truly detect it as negative, that is true negative, then he is again not going to undergo any treatment. He is scot-free, he will go. Okay, a person who is not having the disease, assuming that you are going to predict it as positive, say false positive, right? Then probably you will go for a second opinion, wherein again, say second or even 10 opinions. In one of the opinions, we believe that it is going to be found out that the person is not having the disease, so he will be sent home. Okay, don't worry, you're not going to undergo any treatment, you don't have to. Whereas the real danger is where a positive case is detected as negative. That is false negative or the most dangerous or the most important parameter, which is essential. Why? Because a person is having a disease, but the system says that is not having a disease. That is, it says it's negative, right? A false negative is more crucial than even true positive, they say. So which means this region here, the red region, with as much accuracy this red region is predicted by your system, then only the system is good enough. Now you remember earlier we said that the accuracy is 45%, right? Why do we believe this particular thing? Because if you take the average of the true positive cases correctly predicted, the negative cases correctly predicted, it's only 35%, whereas the accuracy is 45. That itself shows that accuracy is a wrong parameter as far as this particular application is concerned. So again, there is one more parameter called precision. Because of paucity of time, I am just skipping it fast. So I'll straight away go into the F1 score. So what does the F1 score indicate? If you look at the F1 score, if you look at the formula here, it says it's 2 into the square of true positive cases divided by true positive square plus true positive into false negative plus true positive into false positive. From this formula, we can identify that if false negative and false positive cases are going to be 0, imagine this green region is going to expand and expand and expand and make your false negatives at 0. And this green region is going to shrink this positive region and make it smaller, smaller, smaller. But they say that this true negative is not of our concern at all. Okay, what is mainly of our concern is we want to make this region as 0, which means the true positives or the false negatives should be tending to 0. And why this false positive also should become 0? Because only if the false positive is 0, then it means that the system is working in a more accurate manner. As long as there is some element of this false negative and false positive, you find that this F1 score is not going to be 100%. Now, for the same example that I have taken earlier, later on you please go through the slides and you will be able to do a better interpretation. You will find that the real accuracy of the said example is only 28.5% as against 45% claimed by the accuracy parameter. So my humble request to the researchers is, kindly choose the appropriate parameters, kindly choose the appropriate structure to optimize your deep learning or image processing system, because it should be cost effective as well as it should be accurate. Of course, it should be precise as well, but precision combined with accuracy is what is actually preferred, right? Finally, I'll end my talk by saying what are the demerits. Why, when everyone is talking about artificial intelligence in healthcare, what are the demerits we foresee? As I mentioned earlier, reduced skill set of physicians. This is attributed to artificial intelligence. It's a cyclic process. See, more AI, more dependency of physicians on AI. So more dependency, reduce the skill set. Again, reduce skill set, more dependency. So it is actually a cyclic process which ultimately will certainly have a toll on the skill set of the physicians. We do not know what will be the role of the physicians in the next century. Probably they will all be computer specialists, right? And maybe they will have a kind of license. Your MBBS degree or the degree is probably a kind of license with which they are allowed to treat people. But certainly the treatment will wholly rely on computers and other things. Anyway, with the due respect to all the doctors, probably some of your family members may also be doctors. Please tell them not to get offended by this statement. The next one is huge cost of treatment. As of now, common people are not able to afford AI-based healthcare. The cost of a surgical robo is $2 million, right? The cost of robotic laparoscopy surgery is $6,000. The cost of PRRT, I was mentioning, the theranostic treatment is $15,000, which goes above our head. Certainly, I cannot afford it. And even in our own country, recently the RELA Institute in Chennai, they have got an equipment to treat this cancer using radioisotopes. The cost of the treatment is around 15 lakhs or 20 lakhs per sitting, I believe, which means for the whole, the session or whatever, it's going to cost people around 50 lakhs to 1 crore. That's what someone was mentioning, which means it's meant for the affluent. Data privacy, as mentioned in my very first slide, with when we are already losing our data, right, to Google and to whatever, right, Amazon. Everyone is actually stealing our data. Added to that stealing, I think we'll be contributing more to this healthcare as well. And last but not the least, the trustworthiness. What is trustworthiness? We have to start believing in computers rather than human beings. Okay, so I think these are some of the, I don't know when we will be having the same kind of trust. See, as of now, our trust is with fellow human beings, right? We always say the computer can break down anytime, the computer can be hacked, or the computer can suddenly, get repair, faulty, right? All those things. So the trustworthiness, right? Obviously, the present day systems are quite made reliable, but still an electronic system is an electronic system. We know how reliable electronics is, right? Especially the ones from China. And finally, I want to know, before I open the session for questions, what is the next AI revolution? It's a compassionate artificial intelligence. You see from the slide, a robot is actually trying to help a very, aged person. It doesn't mean that we will have to incorporate qualities like love and affection in the robot. I don't think that kind of area is yet to be explored. Though they do some kind of sentimental analysis and things like that, it's a long way to go. So what is compassionate AI? It's quite a different definition. It says that AI which doesn't, rob you of more money, right? I was talking to you about the huge cost. So they are coming out with techniques and tools which make even a common person affordable, which will make him happy. Not only that, minimal pain and minimum invasive, kind of procedures. All these things are actually, they come under the area of compassionate, because as of now they find that AI in healthcare is not compassionate, and they are trying to make it more and more compassionate. So probably this is the thing. If the audience have got any questions, or are there any questions collected through the chat bot, so please let me know, and I'll just stop my presentation. I'll answer the questions. So I wish to thank all of you for your patient listening. I hope I have wound up by the time given to me. Thank you so much.
Thank you, sir. Thank you for your valuable information.
Yeah, it was my pleasure.
Dear participants, if you have any queries, you can post it in the chat box so that we can take it to the professor. Sir, the first question is,
on what about the cell image?
Yeah.
Am I right?
Yeah, that's
I don't know if the question is a cell image qualified enough to be processed through deep learning? That's what is the question. I think it was asked by Miss Manju. Yeah. Yes. Yeah. Thank you, madam. See, deep learning, we know, is carried out by a more complex system, right? See, it all depends on the candidate. To select deep learning, we have to first know whether the the data is complex, it's unstructured, or it requires a more complex number of layers and more complex activation functions. And if the classifier needs to be extremely non-linear and complex in higher dimensional plane and things like that. So merely asking if a cell image would require deep learning is actually, it depends on to my knowledge, if you ask, I will say deep learning is not needed, because a cell image is generally a simple image, right? Probably deep learning will be more suitable wherein you are going to handle more complex images and more volume of images, like as I told you about the various slices in the MRI, right? Which probably it's not possible for us to apply simple techniques. Whereas a cell image is where and again, I do not know whether the question is whether we want to count the number of RBCs or WBCs or whatever. I do not know about the application. But relatively speaking, a cell image is a very simple image compared to most other complex medical images. And if you are going to go into deep learning just for the sake of it, that is going to unnecessarily waste your computing power, and also it's going to ultimately all these things are supposed to come out as practical tools, right? So we cannot pass on this cost to the people, right? See, with a more complex system, obviously the system is going to be more costly, and that way I feel I don't think we can pass on this cost to the people. So it is better that we keep the system as simple as possible and optimal in terms of even the structure, the hardware, the algorithm, the computational time, and everything. So in my personal opinion, most of the cell, the images, cell-based images, unless otherwise the images of high velocity. Suppose if you're going to continuously acquire and send it across, and it requires a high or it carries a high velocity, I don't think there is any reason for us to process it with a deep learning system. This is my personal opinion, right? I think the experts will be able to give you. Yeah, another question is how AI will be useful for healthcare based on. I'm sorry, the chat went away. How do I look at it? One sec, please. Yeah. Yeah, healthcare based on hearing therapy. Okay. Yeah, that's a very good question. In fact, this is one of the areas in which my scholars are working, right? Hearing therapy, right? Obviously, the people who are mostly deaf are dumb as well, right? Because they lack the hearing capability. Because of that, the reproducibility is also affected. So what we do here is, okay, we are actually trying to interpret the sign language. Okay, we are trying to bring in a system which will actually convert the sign language into a kind of we are having a kind of intermediate system which will take the speech and convert it into a sign language and ultimately displaying it to the people. Since the sign language again is a limited scope only, it actually does not require deep learning or anything, because sign learning, the number of gestures are limited. So actually does not require deep learning, but we are trying to do an attempt to do a portable system which will capture the gestures, which will capture the voice and convert it into gestures. This will be useful to people who wish to communicate with the hearing impaired. But to convey it back again, we are also trying to do where gestures can be converted into voice for the people who cannot interpret what is the sign language that is used by the hearing impaired. Okay, this is one work that is actually scope of research in epilepsy. See, epilepsy is associated with the brain signals. Again, see, brain signals are very slow varying signals. The alpha, beta, and those signals are very slow signals. No, I think there is a stream of questions. Probably if I'm allowed to take all these questions and try to give my answer after thinking over, because as the questions are also a bit generic, right? Generic in the sense, I think each answer is going to take some time. And it will also be better, if I converse with the people and then, get to know what they actually mean and what they are working on and what kind of technique they can apply. So I think it is better. So please, I request the coordinators to kindly share my email ID with the participants, so that if there are any queries, I will be able to, but kindly bear with me. I will reply, sure, but it will take it may be a little delayed. It's off and on in between my work. I'll try to spare some time to answer you people.
Sure, sir. We will
Surely,
take
sir.
the.
Surely, sir.
Hello.
Surely, sir.
Yeah,
Surely, sir.
I think I'll just stop here, sir. I think the
Okay, sir.
organizers can take over.
Okay, sir. Okay, sir. Surely, sir.
Yeah.
Now I call upon Professor Dr. M. Prem Kumar, co-coordinator Atal FTP, to deliver the vote of thanks. Welcome, sir.
So thank you, sir. So on behalf of the management, principal, head of the Department of EC, and coordinator of the Atal FDP program on medical image processing and deep learning technologies, I'd like to thank Professor Dr. S. Ganesh Vaidyanathan, in healthcare. So my network is deep learning in healthcare. There's to a network connection.
Sir Prem, sir, you can proceed, sir.
Network connection cut. I think net cut.
Okay, so, sorry participants, due to some network issues, Prem sir could not address it. I will be delivering the vote of thanks. Thank you, Professor, for providing us valuable information. It was really a wonderful session that you take all the participants in the following domains like AI in healthcare. You also explained very deeply about how to use imaging in the healthcare. Also gave us the insights about deep learning and how machine learning is used in the image process field. And really, it was a wonderful experience to have you here, sir. On behalf of PANIMALAR Institute of Technology, Department of ECE, I would thank you for accepting our proposal and delivering this wonderful session to all our participants. Thank you, sir.
So thank you. It was my pleasure, sir. Thank you all, and wish the participants all the best. Thank you so much. Thank you.
Sir, 1 minute, sir. As a
Yes,
token of appreciation, we would like to share the honorarium shield. This is being just due to COVID-19, we are hosting it online. Just we will try to show the image of that so that the professor will receive it.
Oh, okay.
Sir.
I think I'll stop my presentation. It has been stopped.
Yeah, sir. Sure, sir. Sure. I request the participants to pin my screen, Arun Nagasaranya. As a token of appreciation, I hand over this shield to our professor, Dr. S. Ganesh Vaidyanathan, for delivering this session. Thank you, sir.
Thank you, Arun sir. Thank you, Arun sir.
Thank you, Professor. Thank you for joining. Thank you once again on behalf of PANIMALAR Institute of Technology. Dear participants, the feedback link for the session will be posted now in the chat box. I request all the participants to fill the feedback form of this session. And I also request the participants to look into the WhatsApp group for your FDP number. I have allocated an FDP number for all the participants for filling the feedback form. So it will be easy for you to fill the feedback number. You can use that FDP number. The feedback is posted in the chat box. You can fill the feedback. Thank you, sir. Thank you all for joining. And the formal inauguration will be happening by 11 a.m. I request all the participants to join the YouTube live. I will also be sharing the YouTube live link, which is already shared in the WhatsApp group. You can join through the YouTube link.
Okay. Thank you, organizers. Thank you.
Thank you, sir. Thank you. Thank you, sir. Thank you for your valuable presence, sir.
Thank you, sir. Thank you very much, sir.
Dear participants, I'm also posting the formal inauguration link in the chat box. Please do join the formal inauguration by 11. And the formal inauguration will go till 11:40. I request all the participants to attend that through the YouTube link. And we will have the next session by 11:45. I request all the participants to join the next session by 11:45 through the same Google link. Thank you once again for joining on behalf of PANIMALAR Institute of Technology, Department of Electronics and Communication Engineering. Thank you all.
Okay. Thank you, sir. Thank you, sir.